Pleasure to be here. The Ontario Preconception Tool Development on Physicians is really exciting. So again, I know the secret's handshake of family medicine. So it's great to be here from Boston. It's been a rough month in Boston. We had 7 feet of snow, so I had to come to Toronto to get away from the snow. And also, our hockey team is not doing very well at all this year. And we're blaming that on global warming also. But we're here for the next hour or so to talk about preconception care for about half of it, and then about a tool, a system that we put together to help busy clinicians to actually deliver that material, the material that was so nicely put together on that tool. So we'll present the rationale for preconception care, review the CDC Preconception Care initiative, discuss the content of preconception care, and then demonstrate the GABI system. We should all be very proud of a lot that's happened in maternal child health, and this slide shows that the infant mortality rate from about 1940 through 2005 has come down dramatically in North America, and the neonatal rate the same, and the post-neonatal rate the same. We should all be very, very proud of that. But there are some things that we still have to improve on. That's the international ranking of infant mortality, and that the United States, you can see, is the bottom of the pile, which is at 6.1. All these other countries are doing better. Canada is there, which is 4.7, so there's still room for improvement in Canada as well in terms of infant mortality. So the hypothesis is that preconception care is, if we implement it well, can help us to continue to improve international rankings and our infant mortality rates. The other problem that we have, of course, is the vexing disparity between by race and ethnicity in infant mortality. You can see here that non-Hispanic Black women have babies that are more likely to die than other races or ethnicities. And despite quite a lot of work in this area, there's still lots of questions to be answered. But the concept of preconception care, that healthy women have healthy babies, we think is an important one in also solving disparity issues. Some of the rationale for preconception care is that there are many risks to pregnancy that result in poor pregnancy outcomes that are identifiable before a woman ever presents for prenatal care. And why not identify those risks before pregnancy and intervene rather than waiting for pregnancy to occur? And there's just no question that there are a lot of risks that can be identified. And this slide shows that smoking, alcohol, pre-existing medical conditions, rubella seronegativity, HIV, inadequate prenatal care, and those at risk of getting pregnant, you can see below that there's a lot of medical and other risks that are identifiable prior to pregnancy. So why wait till the woman presents to the office pregnant before doing a risk assessment to see if those risks are there and intervene on them? It just makes sense, and it's time to do it. It's also true that we intervene too late, and that the development of the infant in utero is shown here in terms of all the various important systems of the body. But by 12 weeks, in the first trimester, all the major organ systems are laid down, and the first prenatal visit is often not until 12 weeks or later. So those women who don't come in until 12 or 13 or 14 weeks could also benefit from preconception care to improve their risks of having a healthy baby, their chances of having a healthy baby. It's also true that half of all pregnancies are not planned, so that women, not only those who are planning pregnancy, but all women, because so many are mistimed pregnancies, as shown on the far right, or unwanted pregnancies, also deserve to have preconception services. So the rationale for preconception care, just to review, is that poor pregnancy outcomes continue to be higher than acceptable to many of us. There are many risk factors for poor pregnancy outcomes that can be identified before pregnancy. We currently intervene too late and ought to intervene earlier. And that not all pregnancies are planned, therefore preconception care should be delivered to all women. There is evidence that intervening before pregnancy will improve outcomes, and that we're going to review some of that material today. So what is the definition of preconception care? One definition is that preconception health and health care focuses on taking steps now to protect the health of the baby in the future. However, preconception health is important for all women and men, whether or not they plan to have a baby one day. That's the CDC definition. But this is not a new concept. That William Potts DeWeese in 1825, in the first American textbook on pediatrics, said the physical treatment of children should begin as far as may be practical with the earliest formation of the embryo. It would therefore necessarily involve the conduct of the mother before her marriage as well as during pregnancy. So it's a common sense sort of solution that healthy women have healthy babies. Some history is that back in 1989 was the report of the Public Health Service expert panel on the content of prenatal care. This is the first U.S. report on preconception care. I was privileged enough to be part of the expert panel on the content of prenatal care and wrote the chapter on preconception care back in about 1987 or 8. And then the ACOG Technical Bulletin, which is 1990, references our paper about that, and then reiterated that in 2012. So despite a lot of rationale and a lot of data showing the importance of preconception care, not a lot has happened in North America or around the world in preconception care for quite a long time. So we wrote another paper in 1990 in JAMA that asked us to comment on why is there such slow progress in preconception care. And many of these things still are true. That those most in need of services are those least likely to receive them. And that is still true. Provision of services is often badly fragmented. That women for smoking cessation need to go here, for substance use go here, for mental health here, for nutrition here. There's a lack of available treatment services for high-risk behaviors, which is often still true. Reimbursement for doing this primary prevention work is often inadequate or non-existent. That health promotion messages are not effective unless received by a motivated couple. For only a few conditions is there data that intervention prior to conception is better than intervention early in pregnancy. That's improved in recent years, but there's still a great deal of work to do. And that many clinical training programs do not emphasize risk assessment and health promotion skills, and that primary prevention is simply not part of the repertoire of many clinicians who are seeing women and families now. So a lot of this change, that Hani Atras deserves a lot of credit. Hani Atras was at the CDC and pulled together what's called the Select Panel on Preconception Care that met a series of times between 2000 and 2010 especially, but is still ongoing now. And that the Select Panel on Preconception Care put forth 4 goals, 10 recommendations, and 50 action steps for the National Preconception Care Initiative, and organized work groups in clinical care, public health, consumer advocacy, policy, finance, and research and surveillance. And I was privileged enough to be the chair of the clinical work group of the CDC Select Panel on Preconception Care. And in our deliberations and meetings in 2005 and 2006, we said, what is the work exactly of the clinical work group? At that time, there wasn't the consensus on what are the components of preconception care so much. And that people were really thinking of a lot of different kinds of things in terms of what preconception care is. So we set as in our agenda to clarify what our clinical conditions should be addressed as part of preconception care. What is the evidence for each of those items? How can the conditions be best identified? And what interventions are available. And over the next few years, we pulled together about 30 people on this committee who are pretty heavy hitters from CDC, NIH, and others around the country, and then 30 content experts to put together a special supplement to the American Journal of OBGYN that defined, maybe for the first time, the content of preconception care, which is the same domains that was listed on the tool that you saw just a few minutes ago. So that Hani Atras and I edited this special supplement and define the domains of preconception care, as you can see here: health promotion, immunization, infectious disease, etc. And there are about 110 different health behaviors and health conditions that can be identified before pregnancy and not wait until women are pregnant to begin to address them. Within each of the domains, you can see here the kinds of variables or conditions that we looked at to see if it ought to be part of the package of preconception services. And we looked at a standard format for each of those things. So there are some conditions like, for example, asymptomatic bacteria. That is, if you screen before conception and perhaps treat, then you need to do it again during pregnancy. So that was not included as part of the preconception package. If it can be done during pregnancy, it's not part of the preconception package. Group B strep is the same thing. If you screen for Group B strep, there's no advantage to that rather than screening for Group B strep during pregnancy. So it has to be something that the burden of suffering is great enough to justify screening. It has to be identifiable as part of clinical practice. There needs to be descriptions of effective treatments. There has to be effective treatment available for this thing that you screen for. Most importantly, the impact of treating in the preconception period has to be well shown or have a good rationale for that. Then we made a recommendation for each of those 110 different items about whether or not it ought to be part of the preconception care package. And then gave recommendations by other groups, and then strength of the recommendation and the quality of the evidence was rated. So this information is available still in a website. At the workshop before, we went through some of the information on this website. And it's a terrific place that has really pulled together a whole lot of different information on preconception care. And it has a curriculum for nurses and physicians and other clinicians. It pulls together all the important papers in preconception care. And it has a place for special supplements. And there's been a variety of special supplements on preconception care that are out there now. And that the American Journal of OB/GYN special supplement on the content of preconception care is available as a full-text free download for those people who are interested in that. So some years ago, we did something that can't really be done now. These were in the days when women would come to our office to get a pregnancy test, but now they don't do that anymore. And women would come in for a pregnancy test, and if it was positive, of course, we would refer them for prenatal care. And if it was negative, we would maybe send for family planning services, or just say, ooh, that was a close one, we'll sort of see you later. But what we did was to actually do a comprehensive prenatal intake at the time of the negative pregnancy test to see what risks could be identified that this woman could have just as easily have been pregnant because they came for a pregnancy test. So what risks are identifiable before pregnancy that if you intervene on them before pregnancy, it makes a whole lot more sense than waiting until women are pregnant to intervene on. And of course, as you all know, there's an enormous number of risk factors that are identifiable before pregnancy. And they are distributed around the pieces of the pie as shown here. This slide also shows that if your preconception program is simply, for example, a genetic clinic, you're missing all the other pieces of the pie. So this is really comprehensive women's health services that are necessary to provide preconception services in a comprehensive way. So I'm going to give you just a few examples to give you an idea of some of the conditions that have good data surrounding them regarding a preconception approach rather than a prenatal approach to intervening. This slide has a lot of numbers on it. If you look at low birth weight here, this is the effect of maternal cigarette smoking on preconception complications. And then go here, this is the percent of all cases, 11 to 21% of all low birth weight births are attributable to maternal smoking. It's an enormous risk factor. And why would we wait for women to come in for the first prenatal visit to identify that women smoke? When, first of all, it's usually at 12 to 14 weeks when it's really too late. And why not do that before and talk to women about smoking when there are still many women who smoke, as you saw from the earlier slides. and don't know the importance of smoking on its impact on pregnancy. It's an enormous thing. In our negative pregnancy test study, just to give you an idea, there were 136 women that we did this comprehensive prenatal intake on when they had a negative test. And we asked them about alcohol consumptions. Now, I don't know exactly what yearly drinking means to pregnancy, or monthly or weekly. But there were 2 women out of 136, so it's not an insignificant number, who are drinking every day. And I know what that means. Fetal alcohol syndrome is the leading cause of preventable birth defects of otherwise term babies. It's a preventable condition that in our offices, in our clinics, in our facilities, that we can prevent anomalies by addressing alcohol use, at least on a daily basis. This is to give you an idea of the importance of diabetes. And I show this to a lot of internal medicine doctors and residents, and people just are not nearly as aware of this as they need to be. That the overall, if you add together the major and minor anomalies, it's between 1% and 4% total for pregnancies. If you are a woman who's diabetic, whose diabetes is not in good control, and the hemoglobin A1C is high, the rate is 10.9% for anomalies, major and minor anomalies combined. It's an enormous thing, and people are just simply not aware of it. So again, we can prevent anomalies through preconception care. And we can do this every day. Exposure to teratogens is also an enormously important area, and these are not rare medications. The list goes on and on and on. I just showed you a few, but ACE inhibitors are used now, and as women are older as they're having children, and chronic diseases are getting younger, there are a lot of women of reproductive age who are on hypertensive medicines, and medicines for diabetes, and medicines for other chronic diseases. And the ACE inhibitors, quinolones, tetracycline, warfarin, all these things are not uncommon at all and are teratogenic. So by reviewing the medications, doing good medication reconciliation in women of reproductive age, get them off things they should not be on if they get pregnant. At least get them on family planning if they have to take the medicine to the least effective dose necessary. Then we can again prevent anomalies. There's a variety of different things in nutrition, but the one I really want to focus on is this, which most of us know now. But still, as I showed you before, only about 40% of women are taking folic acid every day. This came out in the 90s. All women of childbearing age in the United States who are capable of becoming pregnant should consume 0.4 milligrams of folic acid per day for the purpose of reducing the risk of having a pregnancy affected with spina bifida or neural tube defects. Only 40% do. You can reduce the risk in North America of spina bifida and neural tube defects is about 2 to 4 per thousand. It can be reduced by 2/3 by taking folic acid each day. So this condition, this is a neural tube defect, is a preventable condition by taking folic acid. This is anencephaly, which is a preventable condition. So we can prevent this conditions in our offices every single day through primary prevention, through preconception care. Rubella, we don't see much. Congenital rubella syndrome, we don't see much anymore, but this shows you the importance of preconception care. The vaccine, the MMR vaccine, was licensed in about 1968. So this is the incidence of rubella. You can see how drastically down it's gone. This is rubella in more than 15-year-olds, and this is congenital rubella syndrome, which was here. So it was about 4 per 100,000. It's now negligible. Congenital rubella syndrome is an extraordinarily devastating problem of congenital anomalies associated with rubella during pregnancy. And now, as I showed you before, there's a percent, I forget, but 20% or something of women are still rubella immune now. And simply by giving MMR, you can prevent congenital rubella syndrome. Same thing with HIV. This is the very first study of HIV in terms of vertical transmission. The vertical transmission of HIV from mother to child is 25% without treatment. The very first study showed that it could be reduced to 8.3%. Now is virtually zero with triple therapy. Mothers are identified before pregnancy, are treated appropriately. The viral load is down to 0 when they enter pregnancy, and those women do not pass the HIV to their children. It's preventable with preconception care, identifying those women who are HIV positive, getting them on appropriate treatment, and not letting them get pregnant until their viral load is low. And this is a condition that we see all the time. These are women who are not using birth control, but say they're not ready for pregnancy. so that they are not desiring pregnancy, not emotionally ready for pregnancy, not financially ready for pregnancy, but sexually active and not using birth control. And what do we do about that exactly? So this is an opportunity to do shared decision making and to talk with them about why is it you're not using birth control if you're not ready for pregnancy now. And we see this all the time. So it's an enormous dilemma. Those are just some illustrative cases of the power of preconception care. And this is as important as anything in medicine, that we can primarily prevent these conditions. But it's a kind of condition, it's a kind of care that has not been easily introduced into clinical medicine. That I'll show you in a few seconds. In public health, it's really been picked up a lot, as the Ontario Public Health Association documents. That these papers are coming out all over about the kinds of things we should do. But it's really terrific that the Ontario Family Physicians put together a clinical document that helps clinicians to actually do this kind of care in their offices. So how do we deliver all these things? It's a sort of a paradigm shift. I like to think of it as there's clinical care in offices where you have 15 or 20 minutes to see a patient, and there's public health. But that's not all there is. There's new ways of doing things now. There's a third way. And I think health information technology is everywhere now. And why not use these technologies for what they're really good at? And there's another way of delivering care which could actually improve the way that we do things now. Another important reason to do preconception care, and last week I talked to the Boston Obstetric Society. And I said, listen, there's this thing called the one key question, the OKQ campaign that's coming. The one key question was started in Oregon, in the West, and Pacific West, and that they have asked the question of women in community health centers and public clinics, would you like to become pregnant in the next year? If the answer is yes, they are referred for preconception care services. It's a brilliant, simply brilliant idea. So this is going to be picked up by the Boston Public Health Commission. And it's going to be done at all the community health centers in Boston. And women are going to start being asked that question, the one key question, would you like to become pregnant in the next year? So suddenly, if the answer is yes, then there's going to be all these referrals to family physicians and obstetricians, all this other stuff. And they're saying, oh my gosh, we really have to learn how to do this stuff now. Because it's really never been routinely of practice. So we believe that there's a need to develop an efficient way to assess a woman's preconception risks in order to prioritize valuable appointment time with a provider and to support the woman in taking actions to minimize her risks. So we've spent, as I showed you before, the first 3 or 4 years of preconception care on developing what is the content of preconception care. Now that job is done. It needs to be updated periodically, but it's mostly done. And people mostly agree that these things are important, and there's good evidence to show that we ought to do all that. And then the very last thing was, how do we actually implement these things in practice? So I spent the last few years thinking about that, and how can we assist busy clinicians in actually delivering this material in their practices, because it's simply not being done. So there have been a variety of different websites around. This shows a lot of the interest there is in preconception care. It also shows this mostly comes out of state health departments who work with the CDC. So the health departments are really getting on board in terms of developing preconception health programs from the public health perspective. But that by itself, I don't think is enough. So this is the Georgia website. This is the Dutch. There was somebody who was an observer at the expert panel process from the Netherlands who went back home and they're doing really terrific work. This thing called pre-preg in Europe now. That is pre-pregnancy research and implementation programs. And the Netherlands is really leading the way. And this website, you can kind of get the idea. It's like they have both men and women. And if you're a man, you click there and it tells you what risks there are. And it does a risk assessment, tells you what to do, and things like that. And Colorado has a preconception care tool that looks similar to the Ontario tool. California has a similar website, Pennsylvania a similar website, Delaware, same sort of thing. Southeast California, preconception care websites. Show Your Love campaign is a CDC website. And then various other state programs in Arizona, in Delaware, in Louisiana, it's called the Stork Reality. But you can see there's a lot of interest on the public health side. And people are struggling with how do we actually get these things done. So our work has been in developing a health information technology system that can help us in care to do these services. I just want to give you some background. And at the workshop this morning, we talked about a little of this, so I apologize for those who were there, but just I gave you some background this morning. The next few slides, some of you have seen. But this is work that we've done on virtual patient advocates or embodied conversational agents. That Tim Bickmore, who is my partner, was on the technical side, was a graduate student at MIT, Massachusetts Technology. And when he was graduating, his thesis was developing Louise, who's here. Louise is the prototype for Gabby. And they invited me over to MIT to the media lab and said, because I had to present some clinical issues, and then they had their graduate students present their technologies that had no application. And then afterwards they have a party, and you go outside and you drink wine. And you talk to the grad students and say, so I said, Tim, do you think that your embodied conversational agent could teach patients who are leaving the hospital what to do to care for themselves when they go home? Because that area I was interested in at the time. He said, I think so. So we worked for some years developing this character, Louise. But embodied conversational agents emulate face-to-face communication. So when you see Gabby, you'll say it's kind of like clunky animation. And the fact is it's not animation. That Gabby talks by talking, and then on the side, people respond by clicking buttons. Depending on where you click the button, Gabby says different things. So it's not animation in any way at all. It's really, truly unique software that has been used in this way. And then Tim's area of research is to develop animated characters that can develop alliance through empathy, gaze, posture, and gesture, which we think will improve the transmission of information and to improve health behavior change by making connections with a woman through empathy, gaze, posture, and gesture. In the Reducing Readmissions program, Louise taught what we call the after-hospital care plan. I'll show you that in a second. And it's very tailored to the individual. So it's information in this program that was, what are your medications, your appointments, your pending tests, etc. And talk about specifically things that apply to you. It's a very important part of tailored information to improve behavior change over time. And that's what experienced clinicians do. And then the agents also are able to do this thing called teachback, which is something that we all ought to do, which is when we do some health education to say, okay, I've told you what you need to do. Can you tell me in your own words what I just said? So it's after you teach medications, you say, okay, tell me how often you take your folic acid every day. And it'll be 1, 2, 3, 4. If they get that wrong, there's really something wrong. And they need a plan B. So teachback is a very important technique that we as clinicians ought to do. But guess what? We really don't do that every day. And the nice thing about health information technology is it will do the right thing all the time. So this is the readmission reduction program. So the patient will be sitting in bed and holding what we call here the after-hospital care plan. And it's the same after-hospital care plan that Louise will be holding. And in response to Louise, by touching the screen, Louise will present a variety of options. You touch the screen, how do you want to respond? So this is information that's tailored to this person specifically. So in this program, when we ask people after they receive their discharge instruction from the hospital, who would you rather receive your information from, a doctor or a nurse or Louise? Twice as many said Louise. And why? It was always the same thing. It was just like a nurse, actually better, because sometimes a nurse just gives you the paper and says, here you go, Louise explains everything. I prefer Louise is better than a doctor. She explains more, and doctors are always in a hurry. And it's really, really true. We are always in a hurry. The amount of time between the interns and the residents and the attendings and the nurses and the case managers, all that is about 6 minutes of discharge instruction. And Louise, if there are 4 or 5 medicines, 2 or 3 appointments, is about 25 minutes. And she's sure that you understand, prints out a report later about what it is that you understand, what you don't understand. So I'll give you an idea of what Gabby looks like and sounds like.
Hi there, it's Gabrielle again. But just call me Gabby. We met when you took the survey. You're AA, have I got that right? How is the weather today?
Really bad, Amasa.
I see. I hope the weather gets better.
So we respond differently depending on how the weather is, of course.
Remember last time we talked, you answered all those health questions. Now we can start talking about the health topics that are important for you.
So just to give you an idea of how the system works. We did a lot of work with focus groups that even identified Gabby's name and clothing, accessories, and stuff. We're still working on a lot of those, what we call engagement scripts around hair and nails and all that to get women engaged in the system. Because like folic acid improves hair and nails. And often we'll want to take folic acid because of that reason, not necessarily because of some abstract reason about having a baby in the future that has this, 66% less chance of, etc. So this is what the risk assessment looks like. And so our risk assessment is like the Ontario risk assessment. And this takes about 20 minutes for women to do, and they do it on their own. And this by itself is a very useful tool for clinicians because a woman at home, online, can go through this, or in the office waiting for the appointment can go through this and bring in the risks to the clinician. It's a huge advantage for us rather than having to go through the history to take all this information down. And guess what? Women, if there's 107 different preconception things that ought to be a part of the package of preconception services, women don't want to hear about all 107 of them. They don't want to say, here's the book, read the book. They want to hear about the 7 things that apply to them. And the clinicians don't want to hear about the 107 things either. They want to know what are the 7 things I need to do for this person. Part of the risk, about 40% of the risks are what we call go-to-doctor risks. So there's things like HPV vaccine and pap smear, and get a chlamydia test, and that sort of thing that you have to go to the doctor's office for, get a prescription for something. So in those situations, Gabby will explain to the woman about why these things are important. Do actually motivational interviewing, and we'll talk about that in a second, about getting them from, you don't want to have your HPV vaccine, this is why it's important, and that sort of thing. Get them to, yes, I will go have it done. And then work with them on the barriers of why, of how to get an appointment and how to go see the doctor. And remembers over time, she'll say, next time you sign on, gee, you were supposed to see Dr. Jones last Tuesday. How did it go? You said it was a problem because you didn't have a ride, or didn't have the babies there, didn't have these sorts of things. And we gave you suggestions about this and this and this, and how did that happen or not, etc. That's risk assessment. So risk assessment by domain is here. So the nutrition, infectious disease, genetic, environmental, reproductive, etc. So nutrition is the biggest one. Infectious disease, genetic is here, environmental is here, reproductive risks are here, immunizations, healthy conditions, etc. are the others. So in version 1, which we did a pilot with, there were, to give you an idea, after we developed the Gabby system, we did a small pilot with about 20 women or so. And we found that there were 23 risks of 107 per woman. We said, that seems like that's too much. Today in the workshop, what we did is we presented a few cases, and the group was really terrific. We presented cases that had maybe 3 PowerPoint slides worth of case, and then asked the group, what are the risks? And they were, we didn't count them, but they were probably about 15 to 20 risks per person, just on a case that we presented. So it's the case, the Gabby risk assessment is really very broad, and not only clinical conditions, but also we're really working hard on the social determinants of care in terms of identifying those as potential risks. In our pilot, women are, if 23 risks were identified, and then they're asked, then Gabby will discuss those things that they want to discuss. And women asked to discuss approximately 11 of the 23. And then they can add it to what's called my health to-do list. We used to call it my reproductive life plan, but folks don't use those words. So we add it to my health to-do list, and 7.2 of the risks were added to my health to-do list. If it was added to my health to-do list, then 54% were resolved, and 29% action was taken in those areas. So 84% of the risks were improved or resolved, and we were very heartened by that. Also in that study, we measure the trans-theoretical model of behavior change, that is, pre-contemplation to contemplation to action, etc. And women who were pre-contemplative for a risk, there were 16 of them, but only one of them decided to add that risk to their My Health to-do list, meaning that they were truly pre-contemplative about that. They didn't really want to do anything about it. But those who are contemplative, so pre-contemplative is like if you're a smoker, and we say, doctors, clinicians, nurses say, do you want to stop smoking? And say, no, I have no interest in stopping smoking. They're pre-contemplative. But contemplative is, yeah, I'm really thinking about it. This would be a good time to do it. My kids are around me, that sort of thing. They're contemplative, and they're ready to move forward with action. So if they were contemplative, 11 of the 12 added it to My Health to-do list, and of those, 72% were resolved in the 2 months that this study was going. So from that, we took out that what we really need to do more of is not just take people from contemplation to action, but to take people from pre-contemplation to contemplation relative to all these risks. So we've spent quite a lot of time now on version 2, which adds in what we call motivational interviewing scripts into the system, and shared decision-making to assist in the difficult decisions. And then have designed a variety of different kinds of tools to address all the various kinds of risks that can be identified. So version 2 of GABI works by women will take the risk assessment, which takes about 20 minutes or so, and then they meet GABI, and then they review the My Survey results, which is about 20 risks per woman. And then they listen to informational scripts. They choose which risks to learn about, and they listen to the informational scripts, which are basically, why is this important? Why is this important to my reproductive future, and what am I meant to do about it? And then they answer stage of change questions about where they are. And if they're pre-contemplated, they get motivational interviewing scripts. And they're really fairly sophisticated in terms of how this is done. If they're contemplative, then they get shared decision-making, like let's use this birth control method rather than this birth control method, etc. And if they're in contemplation, plan, or action, then they get homework to do or goal setting, and Gabby will make graphs and charts about how much walking they're doing, how many green leaf vegetables they're eating, or how they're taking the folic acid, or taking the birth control pill, all those sorts of things. And then they achieve the goal, or they keep working on it later. So this is giving you another idea of what the motivational interviewing script would look like. And this would be given to a woman. This one is for family planning. And so this is for the woman who is sexually active, not using birth control, and not wanting to be pregnant with see this risk. So Gabby helps them to work on why is it you're not using birth control, and shouldn't we really talk about using birth control?
First step to good preconception health is being able to control when you get pregnant. Is it okay if you talk for a few minutes about planning ahead for pregnancy? I understand that this can be hard to talk about, and it is up to you. But this is a topic that women often feel torn about, and sometimes it can be helpful to talk about it. It will only take a few minutes. How would you feel if you got pregnant right now? I understand that you probably have a lot of other things going on, so thinking about pregnancy might not be at the top of your list. But if you could choose to be pregnant right now or not, what would you prefer? It sounds like you have some concerns about getting pregnant. Could you tell me more about that? So it sounds like you're concerned that a baby would get in the way of doing things you want to do, but you mentioned earlier that you're not using birth control regularly. Can you tell me more about that? Tell me more. Why do you think you cannot get pregnant? It is true that an irregular period, or a period that does not come at all, could make it harder for you to get pregnant. But it does not make it impossible. Your body could release an egg at any time, and that means if you have sex, you could get pregnant. And did you know that half of all pregnancies are surprises? Many of those are to women who did not think they could get pregnant. And you have said that you do not want to be pregnant right now. How about if we talk about some effective ways to prevent pregnancy?
So you see, so you went from a woman who was not using birth control and sexually active and doesn't want to be pregnant, to a woman who says, okay, let's talk about birth control. And then that woman would get a shared decision-making script, which is then...
Can I ask you a few questions to figure out what might be best for you?
But again, tailored to the specific person. Not everybody would get this. Only this select group.
What is the most important thing for you when it comes to birth control? Okay, thanks. Can you tell me what is the second most important thing for you when it comes to birth control? Great. Now, of the remaining two options, which would you say is most important when it comes to birth control? Thanks for ranking those items for me. It just helps me figure out which methods might be good for you. Based on your rankings, here are 3 birth control methods that might work for you. Here is a chart with some information about each one. It shows how good each method is at preventing pregnancy.
So you can see what, it goes on and on. She teaches about each one of the methods, and that can be printed out and brought to the clinician, and they'll come with some information. You say, I think I'm taking what Gabby suggested. Take one of these 3. I really think I'm going to use this one, and what do you think about that? To promote. So it engages both the woman and engages the provider in the things that are high priorities for that woman. So we're now doing, or we just completed a test with 100 women. There were 100 participants that used Gabby for 6 months. And these were women who were preconception peer educators in the Office of Minority Health. These are women who are trained to be preconception care educators at universities around the country. So they're higher education, high computer literacy. But we thought we would test to see if it works in that group first, and then a more target group later. They're African American, 18 to 34. They're enrolled over the phone. They're given a questionnaire at the beginning for baseline data. And importantly, the controls received a letter listing all their risks. And the letter said, take this to your doctor or your clinician to address these risks. The control group was not nothing. Nothing would change. And this would be, you got this letter, go to your clinician. It's really comparing going to the clinician versus using Gabby and going to the clinician. And the results show that in the control group that 20% of the risks were resolved in the 6-month period. And with Gabby, there were 27.8 of the risks resolved, which is about 30% more risks were resolved using Gabby than saying taking your list to the clinician to address these risks, which is a really highly significant result that we're very happy with. There's also an improvement in knowledge in the nutrition area that was highly statistically significant. When we asked women how easy was it to talk to Gabby, they said that it was extremely easy, very easy, or easy. So almost all, more than 75%, thought it was easy, and very few thought it was difficult to use Gabby. And having used the information from Gabby to improve your health, so 65% of women who used it say they improved their health by using it. So that's really important. And 21.9 said they plan to use Gabby to improve their health, or the information Gabby gave them that will improve their health in the future using that information, which is very important also. Would you recommend Gabby to somebody else? The same thing, 2/3 said yes, and 21% wouldn't. So what's next is that we are now enrolling for a bigger trial of 530 women. We really feel strongly that there's enough technology out there now that hasn't been tested. And you can't go anywhere without hearing about all these gadgets that are out there, the pedometers and watches and things like all these monitors and all this sort of thing that has not been tested to see it's just really improved people's health. So we really feel strongly that before we unleash a new technology on the world, we really want to test it well enough so we know what the implications are, what the impact is of the Gavi system. So we're doing a larger trial of 530 women, and that's being enrolled now. With funds from Kellogg Foundation, we have 2 years of development. We're going to improve the family planning discussion stuff, scripts, and making connections between various risk factors. For example, what we've done is to take, if Gabi works with a woman on taking folic acid every day, and they say as a barrier to taking it that they can't remember to take it every day, and Gabi says, well, here are some things that you can do to remember, and they choose, I'm going to put it next to my toothbrush in the morning, for example. That's one of the things that happens. So she'll remember later when they start talking about birth control pills, that, gee, do you remember that when we talked about folic acid, I suggested you put the pill next to your toothbrush, and it worked really well because we plotted it out over time after that. Why don't you do the same thing with the birth? Because this is what clinicians do, is pull from different areas, make connections with patients, develop rapport with them, and that's what allows for behavior change to happen. And we think that maybe some of that we can emulate. So the Kellogg Foundation money too, the idea is to prepare it for what our computer scientists call shrink wrapping, which is to get it ready for use in healthy start sites in the U.S., which is sites for usually low-income, high-risk women who are in prenatal care. But Healthy Start has made a huge priority in preconception care. So a lot of the Healthy Start sites around the country have a big program component now of implementing preconception care into Healthy Start sites. So we then, if we can get it ready over the next 2 years to be used, our goal is to get Gavi used in Healthy Start sites around the country. So this is not a proprietary product or anything like that. This will simply be developed with government funds and used by whoever it is that thinks it's helpful. And then we're also have funding from a variety of places for men. And that everyone thinks that that men are somehow important in this whole process, but there doesn't seem to be much attention paid to them. So we wrote a grant to various places, and it's a very important topic now to develop what we're calling GABE. So that GABE, Gabe could be working with Joe, and Gabby could be working with Mary. And at some point, Gabby can say, gee, you told me that your partner, would you think your partner would want to work with my friend Joe, or by my friend Gabe? And they say, oh, sure, okay. And then here's the login number. So then they give it to the partner could log into Gabe. So then we could work on first. But the risks for men are really very different, and we're really thinking very long and hard about how to address issues around men's issues, which is education and anger and violence and incarceration and guns and all sorts of things like that are really important to having healthy families and healthy communities. But ultimately, we're going to try to program in where they can actually be. This is more than you think I'm really crazy after I say it. So Gabe and Gabby, and then Joe and Mary. So at some point, Gabe can say, Gabby told me that Mary said that she really would like you to fill in the blank, eat more green leafy vegetables, exercise more, stop, that kind of thing, to see if we can facilitate a conversation about that kind of activity. And then we're going to try to do a second thing too. We're going to start easy and then start something that's even more profound, which is that Gabe is going to say, Mary would like to have a conversation about our relationship and where we're going with it. Because that's really fundamentally what preconception care is all about, is thinking about where we're going and planning for that. And this is a conversation that none of us really ever have. Ever. So if there's something that can facilitate that conversation, the number of unwanted missed-time pregnancies are really very important. If we can facilitate what relationships, what discussions are happening about health, about being healthy together, about having healthy children, having healthy families, that is what we ought to be doing, what we're going to try to do. So this is, I just want to show you, so if we do all these things that we've been talking about, then we're going to have what we call the preconception care baby of the future. You can see this is an ultrasound. So this is the baby's head, and this is they're sucking the thumb here, and this is the legs and the feet down here. So if we really do preconception care the way we hope we can, this is what's going to happen. It's been terrific being here today. It's great coming to Toronto. And just to reiterate, what we talked about is that societal needs to improve reproductive outcomes. We still have a lot of work to do and a lot of improvements to make. But preconception care offers an opportunity to impact outcomes by emphasizing health promotion, risk reduction, and primary prevention of poor reproductive outcomes. That health information technology offers a way to provide this care, and that we ought to take advantage of it. And in the future, the young people who are in our offices, they just have to walk down the street and see kids using these things. They're going to be asking for this kind of stuff. It's not going to turn them off at all. They're going to say, where is it? How come you guys aren't giving me the stuff that we know how to use? The GAVI system has been shown to engage women and reduce health risks, and that larger studies are underway targeting younger, low-income women. I just want to end with telling you a short story about how all this reminds me of the French general who returned from the war to his farm estate. And when he came home, he noticed that the orchard had been destroyed in the war, and he instructed his staff to replant the orchard. And his staff said, "But General, it will take 10 years for the trees to bear fruit." And the general responded, "Therefore, we should begin at once." And so it is with preconception care, and as we heard this morning, early childhood education as well, that we need to start at once. Thank you very much.